All right, we're going to talk a little bit about Chapter 15. I'll try to make this presentation as quick as I can. That way you can have plenty of time to review the content before the exam. Okay, so I think we're all pretty familiar with the term anxiety. We all tend to experience it from time to time. But what's interesting about this is anxiety is a reaction to fear sometimes, but it's also really necessary just for day-to-day life. So when you sit down and take an exam, you have a little bit of anxiety that comes because your body is making that choice of what to do. Are we going to kind of face this exam head on? Are we going to get relaxed and not really do too much about it? Let's take a minute and look at the different levels of anxiety. So these levels of anxiety are here for you in Chapter 15, and they kind of are just a stair step. Mild anxiety, this is normal, this is everyday. It actually does increase our awareness of our surroundings, give us better focus. Moderate anxiety, you actually are able to see, hear, and grasp less information, maybe be inattentive in certain ways. You're not able to completely think clearly, but it's not completely hampered. You may have an increased heart rate, pulse, sweating, maybe even some GI discomfort with this one. Severe anxiety, you're focusing on one particular detail or many of them. Your thought process is not smooth at all. You are not able to learn anything during severe anxiety. And panic is most extreme. I think all of us has maybe seen somebody that's been in a panic, but they can't even process the environment around them. They don't recognize really what's going on. They may be running around, screaming, and eventually this can lead to exhaustion. So question 1 here, a parent is shopping with a 5-year-old child in a large, busy urban mall. The parent suddenly realizes the child's missing. Which level of anxiety would likely result? So I think many of us would go between C and D here as being the appropriate answer. The book is telling us that D, panic level, is the appropriate answer. But really this is to get us thinking about what is the difference between severe and panic. So take a little bit of time, maybe pause the video, and look at the distinct differences between severe and panic levels of anxiety. So if this parent is actually experiencing a panic level of anxiety, what kind of behaviors might we be seeing? So there is a great chart for you on page 281 that looks at the different types of anxiety and kind of separates them. So panic, they may be running around. We can see all the physical characteristics here. Immobility or severe hyperactivity, not really able to speak, lots of somatic problems or body problems. Could even be having hallucinations or delusions at this time too. So this chart for you on page 281 would be a great one to review. Now remember, I don't want you to just be able to tell me that's mild anxiety, that's moderate. I want you to be able to do that, but the next step beyond that is how do we as the nurse respond to that type of anxiety? So we'll get to that just a little bit later in this chapter. What's interesting is that our bodies and our minds, when we experience stress, automatically use defense mechanisms. Now these are not things that we think to do, these are automatic. Coping styles, they protect us from the anxiety that we're experiencing. Many times they block those feelings that we are having. And a lot of times the defense mechanisms aren't all that apparent to the person that's having the anxiety. So they can be healthy or unhealthy. There's a big list for you on page 283 of the different types of defense mechanisms and how we can use them in a positive way and then how they could be used in a negative way. So I think it's important that we look at each of these and figure out, are they using this defense mechanism in a healthy way or are they using it in an unhealthy way? And so you guys can take a couple minutes and look over that table. You may be asked on this exam to explain the defense mechanism that somebody's using, note whether it's healthy or unhealthy, adaptive or maladaptive, those types of things. There are a couple of disorders here that our book points out. One of them is separation anxiety disorder. As far as development for children, we do see this happening in kids, but lately they've been recognizing this in adults. Maybe it began in childhood or in adulthood. So extreme difficulty with romantic relationships, likely to be unmarried. They do tend to avoid harm, worry, they're shy, uncertain. So it's really difficult for them to get into an intimate relationship with another person. Panic disorder, many times we kind of look at this like when someone comes into the emergency room having chest pain, many times we have seen this as a panic attack. So they may not be actually having all of the physical problems of an MI, but having all of the signs that they're having an MI. You know, the standing on the chest, the impending doom, those types of things. And many times we'll see someone coming in having those same signs and symptoms as a heart attack, and it will actually be a panic attack. So we do need to look at, you know, why is this happening, because it is pretty unpredictable. It can happen at any minute. Alcohol and substance abuse is pretty common with the adolescents with this disorder, so keep that in mind. Agoraphobia, this is a fear of big open places. Also, if they feel like might be the center of attention in this place, they're going to avoid that. And then there's a whole list of specific phobias there for you in table 15-4 on page 285. So social anxiety disorder and generalized anxiety disorder are two very common anxiety disorders that we see with our patients. So social anxiety, it really is just as it sounds. They don't want to be out in the middle of everybody. They may feel like everybody's looking at them negatively. So they have a fear that they're going to do something silly, or people are going to think that they're silly, you know, out in the middle of a public situation. They might think they look awkward or sound awkward. Small children with this disorder, sometimes they call it selective mutism, and so they actually don't talk. They hide behind their parents. Sometimes when they go to school, they literally don't say one single word all day long. Generalized anxiety disorder is a little bit different. The person that has this disorder tends to be very focused on worry. Worry, they think about it all the time. It's really out of proportion as to what's going on in their life. They can't sleep. They may have GI symptoms. Many times the worry is about themselves, like they're not doing good enough. Those types of things. Family members of patients that have generalized anxiety disorders really feel like they have to continually reassure the patient that they're okay, that they're doing a good job. Really common for these patients to have difficulty with sleep too. And then there's a couple other anxiety disorders here too. Substance-induced anxiety disorders. This comes along when they use a substance, alcohol, illicit drugs, hallucinogens, those types of things. And then anxiety due to a medical condition, very common, especially with thyroid disorders, because their metabolism is in overdrive with hyperthyroidism. It tends to cause anxiety within the body. And you can look at, cardiac dysrhythmias as also being one. If they're tachycardic, tends to also drive up the anxiety. Okay, so obsessive compulsive disorder starts on page 287. And remember, obsessions are the thoughts that the patient is having, and the compulsions are the behaviors that they are doing, usually very ritualistic. Many times they can exist independently, but most often they exist together with obsession and compulsion, and not just one or the other. So all of these are obsessive compulsive disorders. All of them are anxiety driven, so they think that anxiety is the root of all of these disorders. So obsessive compulsive disorder, many times these are the people that have doubts that they locked the door, they turned off the iron, and they go back and check and check and check and check multiple times. Many times their rituals are not founded, like they have to turn the light switch on and off 7 times before they leave the room, or something bad is going to happen. Many of these cases begin in childhood and can be found as early as age 3, so that's something to think about. Body dysmorphic disorder, many times I always think of Michael Jackson, just not ever happy with his appearance and always changing that. They usually have a very normal appearance, but they view it as not normal. So then you see the obsessions with how their body is and the compulsions maybe following through with changing how that looks. So it could be skin, hair, nose, weight, whatever it may be. They often do keep this disorder a secret, and they never, hardly ever respond to reassurance from others that they look great or normal or, anything like that. Hoarding, I think we're pretty familiar with hoarding since the television shows on TV, but just keeping an overaccumulation of belongings that really have no value, and it interferes with their entire life. Hair pulling and skin picking disorders, usually because of stress, once again, and or anxiety. A lot of times we see this beginning in children, even very early in infancy. The pain of the hair pulling does sometimes reduce anxiety, similar to someone who maybe does cutting, and they might not even be aware that they have the disorder until there are huge chunks of hair missing. I remember growing up, there was a little girl that went to our grade school that just hardly had any hair, and it was because she was actually pulling hers out while she was sleeping. So she was not at all cognitive that she was actually doing that. So it was, a coping mechanism or defense mechanism for her there. So you can go back and look at, why this happens in people, who it most commonly happens in. Comorbidities, we do see a lot of psychiatric comorbidities with patients with anxiety. It's about 90% of the time with general anxiety, 84% of the time with those with agoraphobia. So we do see a big link there in comorbidities. Neurobiological, the etiology there is something I want to mention, is that we do see lots of neurotransmitters playing a part and in causing anxiety and in the reduction of anxiety. And so many of our medications are based off of the idea of how our body naturally works. So GABA is a neurotransmitter that inhibits or puts the brakes on the excited neurotransmitters, and so many times our meds will focus on GABA, increasing the amount of GABA. That way we can stop those neurotransmitters that are overly excited. So an application of the nursing process here, remember the nursing process is just a means of helping you think like a nurse. So basically what I want us to look at here is assessment. What are we really looking at with assessment? We need to look at the generalized assessment of the patient, what they say their symptoms are. Remember, it's patient-centered care. They are the ones that need to be telling you how they're feeling. We also do need to do a little self-assessment, because many times whatever behaviors our patients are experiencing can also show those within us too. So if our patient is anxious and kind of out of control, it's easy for us to feel frustrated and anxious as well. As you go through the nursing diagnosis, there's a lot of those there, but remember, what is the thing that we are focusing on most for our patient. So when we look at planning, we want to make sure and encourage their participation, because some of these anxiety disorders have a tendency to have them be isolated. They want to isolate themselves to reduce that anxiety, but we want to encourage them to participate. Although we do have to remember, when they're having severe levels of anxiety, it's not always best to participate at that time. Okay, so now's the time we kind of break our types, our levels of anxiety up into two groups. We break it up into mild and moderate, and then the other level would be severe to panic. And we look at how we can therapeutically intervene with these patients. So mild to moderate, many times they're still able to solve problems, but as we get into the more moderate levels of anxiety, the ability to concentrate is decreased. Many times when their ability to concentrate is decreased, it can make the nurse feel a little uncomfortable, and so we have the habit of trying to change the conversation. But when we do that, that can actually increase the patient's anxiety. So remember, we have to stay patient-centered and focused on what their needs are versus our needs as the nurse. So as long as we can provide a calm presence, recognizing their distress, and being willing to listen, many times that's very helpful for what we can do for these patients with mild to moderate. Now, if you look on page 294, it gives us some really great examples of how we intervene and why we do that. So you guys can read that. It's on page 294, table 15-11. Now, severe to panic levels of anxiety, we do also need some different types of nursing interventions for these patients. We have to make sure we're meeting their physical needs to prevent exhaustion. Usually, once again, a quiet environment with minimal stimulation, and medications are usually considered at this point. But we don't usually use restraints unless we have kind of used up all of our resources and we're not able to keep the patient safe with least restrictive measures. When they are experiencing, our patients are experiencing out of control levels of anxiety, we just have to keep them safe from their own impulses, and many times we're not asking open-ended questions. We're giving firm, short, and simple statements to them. But you can look over the interventions on page 295, table 15-12, to get a little more specific on what you are wanting to accomplish. So what would some appropriate interventions for a parent whose child is missing at the mall and is experiencing a panic level anxiety? So we would look to this chart, or to this table, 15-12. We want to maintain a calm manner. This is going to help with communication. We want to stay with the person. We never want to leave them because they'll feel abandoned. We want to minimize the stimuli in the environment. Move them to a quieter setting if we need to, but remember to always stay with the patient. Clear, simple statements and repetition. Speak slowly. If there's anything that they are seeing or believing is there that isn't there, we want to try to reinforce reality. And you guys can listen or read through the rest of these on page 295. But those are some of the interventions that we use for severe to panic anxiety. So pharmacologically, I just have a few things I want to straighten up. Your guys's ATI lesson that you listened to is wonderful for this, but there's a couple of things that they said that I think I want to make sure and reiterate. Buspar is a non-benzo. It does take up to 3 to 4 weeks to notice the effect, but this is not a short-term medication. This is actually used for long-term, and I know on your ATI tutorial it listed it as a short-term. I just want you to recognize that Buspar is used long-term, and that's okay. The rest of the information that you got on the tutorial was really great, so I would refer back to that when studying for your meds. And then these are some advanced practice interventions. So remember, we are not training you to be advanced practice nurses, but there are some things listed in here, especially in behavioral therapy, that is very helpful when dealing with someone that is having an acute exacerbation of anxiety. So relaxation training, breathing, modeling, we are going to show that appropriate behavior. Systematic desensitization is for somebody that has a fear maybe of an object. And so you go through a series of steps from least frightening to most frightening, and as you move up through these steps, it's supposed to be less anxiety driven for them. And kind of the opposite of that is flooding, where basically if someone is afraid of mice, you just like put them in a room full of mice. And hopefully that, I haven't seen that be as useful as systematic desensitization, but some people respond to that. Thought stopping is maybe when they are having an obsessive thought, they put the rubber band around their wrist and snap that to help stop that thought process. So a couple of questions here. What is your usual level of anxiety on a day of a nursing exam? Now this can be different for everybody, but I want you to take a look at what your level is, and is that impeding on your success on an exam? If that is, we probably need to talk that over and come up with some strategies to help lessen that anxiety. The television character Monk appears to have which anxiety problem? And if you're not familiar with this show, it's going to be really difficult to answer this question. But the answer here is D, obsessive compulsive disorder. So if you're looking for an example for OCD, go to YouTube and look up Monk, and that would be a great example. If you have any questions about this content, please shoot me an email or ask in class.